Good evening, ladies and gentlemen. It's a great pleasure to welcome so many of you here to the Liverpool Medical Institution. Particularly delighted to have the members of the conference that are attending in Liverpool over the next few days. On the screen in front of you, there's a thing called a QR code. For those of you that have any professional need to demonstrate continual professional development, if you scan that, you can type in your name and email. I see people are getting their phones out already. And as if by magic, in a few days' time, a CPD certificate will arrive in your inbox, along with a copy of our programme. And the idea is that you'll be so thrilled to have received a copy of the CPD certificate that you will be inclined to join up and join the Liverpool Medical Institution. We're not very expensive. We survive through our membership. And we are the oldest medical institution in the country. We're older than the Royal Society of Medicine by quite a few years, and we would love to have you as members. There you are. Now, we've got two eminent speakers this evening talking on innovations to improve outcomes from postpartum hemorrhage. Two inventors speak. Andrew Weeks is Professor of International Maternal Health Care at the University of Liverpool and an NIHR senior investigator. Andrew's primary interest is in the translation of maternity care from our high resource settings to low and middle income settings. He has a particular interest in a drug called misoprostol. Have I said that correctly, Andrew? Close enough. Close enough. And he runs a website, and it's all about the use of that drug in postpartum hemorrhage and the management of labour. He's also quite interested in developing medical technology, and he's patented 3 devices. Now, I've only got 1 patent, but to have done 3 patents is pretty impressive. One of these is called the Postpartum Hemorrhage Butterfly, and this has been funded in 2 successive grants by the NIHR. Any more grants? No? Just is 2 enough?
In preparation.
Oh, he's got another one up his sleeve.
Yeah.
This is why paediatricians can't get any grant money these days. And this device was named the 2015 Innovation of the Year, and he was a finalist in the Plastic Industry Awards. So not all plastic is evil. We also have Dr. Graham Tydeman. Is it Mr. now or Doctor? Because some of you obstetrician gynecologists waver between Doctor and Mr.
Doctor in Scotland, Mr. in...
And you're in Scotland at the moment. So Dr. Tydeman is a maker. He's a polymath artist, sculptor, and he makes automatons, furniture, and medical devices. He says he still occasionally practices as a consultant obstetrician, and he has developed several medical devices and many training mannequins. Most recently, the Tydeman tube, and perhaps this is his most important contribution, which relieves the impacted fetal head at caesarean section. He's also the inventor of the blood clock, and the blood clock is outside and will be unveiled in the foyer at the end of our talks this evening. So please don't rush off at the end of the evening. There's going to be quite an impressive piece of kit turned on for the first time in Liverpool outside, and so you'll be able to see that. Now, gentlemen, have you decided, have you tossed a coin? Dr. Tydeman is going to take the stare. Thank you very much. Please, could you welcome Dr. Tydeman?
I've changed the title a little. That's what you do. Thanks to Callum. Thanks to you all for coming. Thanks to Andrew, who was really key in getting the blood clock here. It's quite an emotional moment for me. I really struggled to get into medicine. I didn't do very well in my A-levels. I had to resit them. I'm confident I wouldn't be a doctor now if I was a young person now. And that's a theme I'm going to explore. I'm not going to teach you anything. This isn't a lecture. I'm going to throw ideas at you. And if some of them stick and resonate, then maybe that will spark a thought and an exchange of ideas. Because for me, the creative process is exchanging ideas, and that's something that we have to foster and develop. Because if medicine's ever going to change, if medicine's ever going to improve, we have to challenge what we do at the moment. And largely at the moment, that's confined to people who do academic medicine. And why shouldn't that be everyone, from medical students right the way through to retired consultants like me, nearly retired? It's quite emotional also because my mum was born not far from here, and she was a nurse, and I think in a different world, a different time, she'd have been a doctor. And if she was alive today, I'm filling up really just thinking about this, she would have been so proud, particularly when I struggled to get in to do medicine, and to see me here talking in this fabulous institution among such an amazing audience, it just fills me with pride. Before I go on any further, what I'd like you to do is to please get out your phones. I'm going to do it as well. And I'd like you to go to a YouTube app if you've got it. And if you haven't got it, just go to any browser. And then I'd like you to search on the search function. I'm going to do it live to see how long it takes. The blood clock. Right. And because I've done it before, it's up there. But and then I'd like... Someone hasn't got it on silent, that's fine. Now stop. Now, how many of you resisted the urge to go, oh, I've got a WhatsApp from my family group, or, oh, I've got a new email or a new tweet? We are awash with information, and it's crept up on us. 20 years ago, information, or 40 years ago when I was a medical student, to get information you had to go to the library and you had to get a book out, and then a week later you'd get that paper. And now we get disappointed if you don't get it in the next 5 minutes. But also, coming along with that is noise. We are overwhelmed with information. One of the themes I'm going to explore is the fact that when this great institution, these magnificent people that I'm humbled to be standing next to, started their careers and started this institution, information was really difficult to come by. If someone had a bright new idea in Paris, how long did it take to reach Liverpool? And part of the reason this building and this institution were put together, my understanding was because people were hungry for information, and we're now overwhelmed with it. And hold that thought, because I'm going to come back to it after I've talked about some other stuff. Creativity. Creativity requires challenging the norm. It requires a process where you say, I'm going to think about what's being done and try and think about it in a different way. And my argument is that we drum creativity out of people. This is the 2024 entry requirements. Pretty much you've got to get straight A's first time. If I'd been 4 hours younger, I'd have been the oldest in the school year below. And we've known for a long time that when you're born matters. You get more likely to get straight A's if you're born in the first 6 months of the year. Who are we excluding? Is that the best way of finding our doctors of the future? And we know for ages that if you're female, you're more likely to get straight A's first go. Nothing wrong with being a slightly older female, but who are we excluding in those processes? So people like me who failed their A-levels and they went to a college and resat them and then eventually got the grades wouldn't be doctors now. We'd have had to really, really stick our heels in, do a degree, and then try and get in on the second time. And if you haven't seen it, please look at this. It's now been on YouTube. There's a lot of references to YouTube here. This has been on YouTube for over 10 years. Changing Paradigms by Ken Robinson, who has now died, but he's an educationalist. And this is one of the most beautiful shorts on YouTube that I've ever seen. And when I saw it, it made me understand. It resonated with me. I thought, That's me he's talking about. Why is it that because I was not only the youngest in the year, but also, I'll own up to this, I was physically and emotionally immature. I was the last in my class to get pubic hair. Why is it that I would have effectively been excluded from being a doctor because I was immature? I was also doing lots of other stuff. I was flying a glider by the time I was 16, and I sailed across the Atlantic in my 20s. So why is that the best way we can choose doctors? Because I think what we communicate by saying getting straight A's first time is shut up and listen. There is one answer and you better learn it. Shut up and listen, shut up and listen, shut up and listen. Then you become a medical student. Shut up and listen, shut up and listen. You've got to pass your exams. Then you do your specialist training. Shut up and listen, shut up and listen. And then, some of you become academics and now question everything. And have we encouraged the creative process in that? I don't think so. And I'm just going to quote one thing from this. There's this beautiful study that is quoted on this, where they get a cohort of people, a large cohort of people, and if you're a clever psychologist, you can measure creativity, and they go, whoa, this cohort of people had 80% creativity. They're really great. And then they get another cohort of people, and they go, well, yeah, okay, well, it's 60% creative. And then another cohort of people, and they go, well, you're only like 35% creative. And the trend just carries on. And what they reveal at the end, as I'll reveal to you now, is that they're the same people. It's just that they were 5 years old in the first analysis, they were 10 years old in the next analysis, they were 15-year-olds in the next analysis. So creativity diminishes as we become cynical and as we become constrained by what we think can be achieved without really thinking outside the box. I hate that phrase, but I can't think of a better one just now. And that's for everyone. If we look at, for those rarefied group of people who these days become doctors, they're all lovely. All my medical students are lovely. They're charming, interesting individuals, and they're all captain of the rugby team, and they all got straight A's, or the hockey team, or whatever. But if you ask them to say, tell me something I'm doing wrong, they kind of look at you like, I have no idea what you're talking about. I was lucky enough, with my dad being an artist and my mum being a nurse and having an interest in making things, to always stay a little bit creative. And this is me. One of these is me. Leave you to get to it. I'm not the dog, I'll give you a clue. From my second year of university. And I always felt like a square plug in a round hole. I struggled to get into medicine, and then when I got into medicine I thought, are these really my people? And then when I qualified, I did well at medical school. I got asked to do an intercalated, which was in those days only the top 5% of students. I did an intercalated degree. But after I qualified, I just thought, I'm not sure where my niche is. And I wish I'd taken a photo of it. But when Andrew was showing me around where he lives in Liverpool the other day, there's this beautiful sculpture from 1850, something like that, carved into the wall. And it says, here's your niche, find it. And then there's a blank space. And we all deserve the right to explore and find our niche. And I did eventually, I struggled to find my niche, so I gave up being a doctor. I sailed across the Atlantic and I travelled around South America, and I worked in a war zone in Nicaragua for political reasons for a while. And then I came back and thought I could be an artist. This is a clip from my website, and I started making things. And then eventually medicine called me back, and I found my way back, and my niche was in obstetrics, and I've been a consultant in obstetrics for 25 years, and they have been wonderful. I've had the best 25 years, and I continue to have. Somehow I managed to get the balance right between being the oddball and actually being okay. And this letter was written to me by Callum McNaughton, who was the president of the Royal College of Obstetrician. He was the emeritus professor of Obs and Gynae in Glasgow, and I was there as a 6-month GP trainee and he found the time to write to all of his GP trainees. I bet that doesn't happen now. And of course, the last line is what appeals to me. At that point, I hadn't really discovered it. So when I became a consultant, I started making stuff, and I was still working in performance art quite a lot in the 90s, a lot of kind of big environmental art shows, but I also started inventing stuff for medicine. I think being a consultant is the right time to look back and reflect, and I could talk with great authority about what it takes to get a product to market, because each of those boxes contain a fresh, half-finished idea, none of which made it. But eventually I did get a product to market. That's a young me and an even younger Gordon Brown, and I invented a integrated digital ultrasound archive, telemetry, audit and reporting system, and I learned so much from that because I didn't protect my intellectual property, I didn't have any commercial agreements, I spent hours and hours working on it, but at one time it was really great. You know, I could be in an operating theatre and we're a split site hospital and a sonographer could be scanning 12 miles away and she could be concerned about a baby's head, so she could quietly record 10 minutes of it, ring me up while the woman had a coffee or went for a wee, and say, Graham, look at that video, and I could, at the end of the case, look at the video and go, yeah. And you could talk all day about telemetry, but it's a triaging thing. So I could say, yeah, I agree, this is acrania, and carefully, I'll see her at the end of the operating list. Or actually, you know, that's just a bit of bright bowel, I'll see her on Tuesday if she can come, or put her on the phone and I'll counsel her over the phone. So we had this massively integrated system that eventually went to the subspecialty in Edinburgh and to the other clinics like the paediatric cardiology clinics, but it died. At one point it was in a third of UK units, and when the company I developed with were bought out by a bigger company, I had no control over it at all. So it made me realise that inventing stuff is not just about having the idea and even getting it implemented. You have so many other layers that you've got to think about, none of which we're trained in medicine. So when I next had an idea, and there's a medical company called Ethicon who makes sutures, an development officer from Ethicon, someone quite senior, set up her own private company to try and develop ideas. She came to me and she said, Graham, have you got any ideas? Well, I have. I've just handcrafted a fetal heart. So when we scan women to look for fetal heart abnormalities, we scan them in specific slices, and I wanted to get so much obstetrics, and certainly sculpture is getting two-dimensional images into a three-dimensional form locked into your brain. So I dissected a lot of fetal hearts at the pathology department and then handmade a fetal heart about the size of a large orange. And we said, great, this is a workable product. We'll, I went to my shed and I used to mould them out of rubber, and she did all the marketing. We had proper commercial agreements. You can't really, we intellectually protected intellectual property where we could. And after about 3 years, we folded the company. I'd made 30 of them. I'd spent hundreds of hours. Not that I'm in it for the money. I think I made about 200 quid, and it worked out about 50p an hour. And just before we folded the company, technology had moved on, so I got a CT scan done. So we got the heart model as an STL file, which can then be emailed anywhere in the world, and anyone anywhere in the world can then print it off. But we then thought, well, how are we going to communicate this message? So we got a bit more funding, and I did a teaching video, and this is quite a while ago, 2016, and it suddenly became really popular, and I suddenly thought, the rise of social media, the noise of information overload, which is in stark contrast to what these people had, is we need to use that wisely. We need to move with the times. So I made this video, and now it's got 100,000 hits or more. And if any, we can exchange ideas over YouTube. People will ask me questions about it, and I'll answer them. And if they want a copy of the heart, I just send them the STL file and they print it off wherever they are. And it's a great network of people, and it's led to an interesting network of research ideas. I was in Canada last year as a result of this, on a collaboration there. So we've got to move with the times, is my message. So I learnt that with the fetal heart, particularly because we folded the company, and actually it was the YouTube video that had much more impact than the model itself. What does it take to take an idea from reality to reality? Well, there's lots of steps, and you can't do it on your own, and you need a team. You need, top left, someone who is going to do all the stuff you don't want to do as a doctor. It's going to sort out the patents and the commercial agreements, and Deb's there is from Guy's and St Thomas's commercialisation department. My R&D department in Fife, well, it's only a small DGH in Fife, but my R&D department were fabulous. Below there and at the back of the audience here is Professor Shannon, who brings intellectual and academic gravitas to the whole process. Middle is Annette Briley, who's a professor of midwifery in Australia, and I'm the guy with the shed who make the first version of stuff. And we've now produced a handful of commercially successful devices, with many more in the pipeline, and it's because we function as a team. On the bottom left there is a cervical cerclage simulator that we made a few years ago, and I did a little video of me doing a cervical cerclage, which I put on YouTube, on my YouTube channel, and again, we've now got about 100,000 hits of that. Now, if you'd written a paper and you knew that 100,000 people had read that paper, how pleased would you be? And of course, as well as YouTube, you can use, the social media I use is Facebook and Instagram. I quite like TikTok, but I haven't quite gone there yet. Andy does the tweeting, so we have to move with the times and communicate our ideas effectively. One of the thoughts I've had is maybe what we need to do is to have YouTube Scholar, because of course this isn't peer reviewed, and there's a lot of fake news and all that stuff, but the days of having a paper published and read at that lectern and the people in the audience going away and being aware of it have gone, particularly in the last 10 years. They haven't gone, but we need to be much smarter, I think. So, the blood clock. Well, with my role as an obstetrician, with my role as an inventor and a sculptor, the chief investigator of the blood clot of the woman trial, which was a huge randomised trial in women with postpartum hemorrhage, randomising to tranexamic acid or placebo in low-income settings, said we're going to publish our results in the next year. And he and I had a beer in London, and we said, it's amazing that you've got the New England Journal of Medicine and the Lancet competing with each other to publish your results, but these days we're increasingly hidebound to a certain extent by guidelines, and actually as a multi-pronged approach, if we could make a sculpture that was almost brutal in its impact, that got across the point from Andrew's research that once every 6 minutes a woman just bleeds to death. And then we put a video of it on social media. Then in the time it would take for the Lancet paper to be reviewed by the RCOG guideline and that be adopted by a country in Nigeria, say, in Africa, say, thousands and thousands of women would die. So why not try and get this information out there sooner? So that's why I was asked to make the blood clock. And the woman trial followed the CRASH 2 trial, which was trauma, a very identical trial, 10,000 people who had trauma, 20,000 people had trauma, 10,000 randomised to placebo, 10,000 randomised to tranexamic acid. A third fewer people died with tranexamic acid arm, and Ian was presenting this at the wound up of the collaborators, and the doctors in Nigeria said, well, this is all very interesting, but actually the most blood comes out of women. in that unit where he was presenting it, there was a motherless baby unit because so many women died and didn't have, and their babies survived. So they had a whole unit for babies to be looked after when their mother had died in childbirth. So he said, well, let's do a tranexamic acid trial in women. So a little bit on tranexamic acid, because this informs the design of the clock. It was invented in Japan in the 1950s, and I think often neglected. We used it in women with heavy periods, but we didn't use it in massive hemorrhage. Well, I certainly didn't. And it's not prothrombotic. What it does is stop your body breaking down the clots it's already formed. So it's cheap, it's heat stable, you can whack it into a woman who's bleeding. And there are now there was a systematic review, there are now 250 randomised trials in different specialties of people bleeding from anywhere, from thoracic surgery to knee surgery to whatever. And if you give tranexamic acid, no excess deaths from thrombosis, but much less blood. And of course, for every woman who doesn't die, every woman who dies, there's loads of women who suffer the long-term consequences of massive, massive blood loss, the kind of stuff these guys were familiar, necrosis of your pituitary, necrosis of your adrenal gland. So the blood clot, my remit was to design a piece of art that graphically, almost brutally illustrates what massive hemorrhage looks like. Link it in to once every 6 minutes. So I made a clock, which we'll see afterwards, that tells the time in a digital format. It chucks 2 to 2.5 litres of blood into a sump, and the energy from that moves the minute hand on 6 minutes, and that counts off one more death. And then it refills and counts off another death. And it's made with all sorts of stuff that was inspired by my job as an obstetrician. So the sumps, the storage vessels for the blood are baby baths out of a maternity unit where thousands of babies have spent their first days. There's instruments that we use to dilate the cervix if there's retained products of placenta, which can cause postpartum hemorrhage. There's a wound retractor that determines how much blood is released. So I've used discarded medical instruments and machinery to kind of reference it. The main power comes from a fountain, a Japanese fountain to reference the maker, which is a Shishi Odoshi fountain, which you'll be familiar with, and that's to pay homage to the woman who invented this stuff. And the gears themselves that drive the clock round, years and years ago, a friend just gave me a bag of gears and said, you probably want these, and they sat in my workshop for years, and they came from an old church clock in Clerkenwell, and that I did the research on it, and that church clock had been only yards away from one of the very first lying-in hospitals, maternity hospitals in Britain, in London. So I've tried to reference that all the way along in the construction of the clock. And then, of course, we made a video, and my daughter's company made a beautiful video of it, which I started this talk with and I'll conclude with. Please look at it. And if you haven't noticed them already, these guys, hello Farry, are recording this presentation. We've spent the last 2 days rebuilding the clock in the LMI and making a video which sometime next year, we're going to have a big launch of this on social media, on YouTube, and a beautifully crafted video is what I anticipate, that will make it not just a historical piece for a museum of this great importance, a collection of this great importance, but also keep it alive and keep it contemporary. Thank you.
Thanks very much, Graham, and thanks very much for the invitation to come and talk here tonight. It's quite an honour to come and speak here. But I thought that instead of giving something of a scientific lecture, which is what I'm used to giving, I would tell you a story. It's really the story of how I come to invent. And I guess a little bit like Graham, you've got to have a whole number of different things which come together in order. And I want to tell you the story of the PPH butterfly, which Callum talked about at the beginning. I guess I have my wife, Prue, to blame, who's sitting at the back here. She, I guess, was the originator of all this. And it goes back over 10 years ago now, when she and this friend of hers had this rather mad idea that my wife would carry a surrogate pregnancy for her friend. And they came to me and said, "Oh, you're the obstetrician, what do you think?" I said, "Well, I think it's a bit of a crazy idea, but in truth, they were both in their 40s. They wanted a go at it. I thought, well, the chance of success really is pretty low. It's important. It's a generous act. That's good. It'll never work. But so, blow me, 6 months down the line, there we are with a positive pregnancy test, and off we go. Fru had carried 3 pregnancies very successfully, and I think it's fair to say had enjoyed pregnancy. And so had 3 births, straightforward, 2 of them water births, and it had all gone very nicely. So we were looking forward to a nice pregnancy and something equally successful. And it came to the labour, and we were all geared up for this, spontaneous labour. There we were in the midwifery unit, a pool birth, and the labour went very nicely, and then came to the time of pushing, and we thought, right, here we go, we're just about to welcome the little one. The genetic parents were there as well. This was going to be a beautiful moment, and she started pushing, and half an hour later, she was still pushing, and the midwife and I exchanged glances and thought, well, half an hour and somebody's already given birth 3 times. It's not supposed to be quite as difficult as this. And the obstetricians in the room will be already thinking, okay, but we thought, no, that's only half an hour, that's fine. Another 3/4 of an hour, still pushing and nothing to see. And an hour came, and midwife and I looked at each other and we said, "Oh goodness, we're going to need to get the registrar in. This is clearly out of position, and this is all turning out to be a disaster." And I had visions of having to go to theatre to have rotational forceps and such. So we discussed this, and Fru said, "Well, just let me have another couple of good hard pushes," and with I don't know how much it had an effect, but with that final push, she suddenly felt something give, and out appeared a baby's head. And a couple of minutes later, out followed the baby, and anyone who knows me, the cord clamping clearly was intact. This is a critical moment, and the baby was happy, and everyone was looking pleased with each other, until appeared in the water suddenly an oozing of blood, and we call it the shark attack moment. Suddenly you could see in the water blood forming, and at that point suddenly she got out of the bath, the emergency buzzer was pulled, and the poor SHO on duty that day came running, and not only thinking, where on earth is the midwifery unit pool room? We have our PP. Where on earth is it? And then I'll always remember her face as she came into the room and said, "Oh no, it's Prof Weeks' wife. This is my worst nightmare. A postpartum hemorrhage in front of Professor Weeks in the midwifery unit pool room." They did brilliantly. And of course, we treated as you would do any time. We gave the standard utritonics, the placenta came out, and we were thinking, oh, is it stopping? Is it going to stop? And it finally stopped at about 1.5 litres. And actually, everything was fine. HDU, and a couple of days later, home. Now, the strange thing is, it's a little bit odd being an obstetrician and a creative thinker when in that time immediately after birth, because you're quite sort of hyper. And normally you've got a baby who's keeping you completely alert and keeping you full of tasks. But in fact, the baby had gone with the mother, and of course, the relationship is fantastic. It's a very happy ending. We still have lots of communication. But there was Fru, who was at home, but then had moderate anemia, was sleeping a lot. And so what does any self-respecting academic do? Well, of course, they go to their shed and think, why did she have a PPH? And surely there must be a better way of dealing with that. If you've got somebody who's in this sort of situation, it seemed likely that the head had been in this position and then suddenly rotated, which fits with a sort of spiral high vaginal tear. And yet we treated it as if it was a uterus which wasn't contracting well. And that's what we do. That's what we always do. But it occurred to me, well, there must be a better way. Why can we not work out? All we do is see bleed and we think, bleed must be atonic, so we pump the person full of drugs. And so it got me then to thinking, well, hang on, how can we try and determine where the blood comes from? And if you think of the uterus, there's really two main places that it comes from. It comes either from the uterus not contracting, or it comes from tears lower down. Now that's quite interesting, of course, because there's a clear line which separates those two. If it comes from above that line, it's almost certainly an atonic uterus. If it comes from below that line, then it's almost certainly a tear. Why can we not work out exactly where that bleeding is? Then we wouldn't have to give her all the drugs with the side effects in the assumption that it's an atonic uterus, which, to be fair, most are. Why do we have to do that? Why can't we work out exactly what the diagnosis was? So there was me in my shed with Fru asleep, trying to work out how you could do that. And the first thoughts that I had were that actually if you had some kind of a funnel or a cup which went over the cervix, then of course you could easily determine what was coming through that cup and out from the outside, and you know exactly where it came from. But actually it would be good also to put some pressure on the uterus. And so in the days following the birth of our goddaughter rather, actually what happened was I invented this. Now, this is a bit of a strange thing, and you might recognise that this here is an old cream bottle with a bit of polyfiller over the end and the edge cut out, and some paper clips put together, and some blue tack here to hold the paper clips in place, and this is a spacer of an inhaler. These are some old clips which I found in the garage, and I thought, we should try and work out how much pressure is too much, because actually nobody knows how much pressure to put when you put pressure on a uterus. And I thought, Andrew, goodness, what has happened to you in the days following? I thought, oh, you're going mad. You're just hyper with excitement of the occasion. And this was all put to one side for a couple of months. But then as time went on, I thought, there's maybe something in this. And it so happened that another project was finishing, and I came back to this to say, well, along with Graham, it's funny looking at your room. I have a similar room at work with boxes of. I was looking the other day, and I've had 15 different inventions over the years, and in fact only one of them has made it to proper commercial sales. But that's the way of it, that you get a whole number to start with, 3 you get to clinical testing, and 1 comes out the end as something useful. There's quite a wastage. So I started playing around, and these were the designs that I initially did. Well, how do you get a big platform into a space where the entrance is small? You need something small to go in to start with and then open it up. And you can see the original designs here. This is a flange, so you can't over-insert and cause damage. My idea was that we'd still want this channel here, so you'd have an arboreal pattern there. And then we went to NIHR who do a scheme called the Eye for Eye scheme with this idea. And they were quite taken by it. And this actually is, we're trying to find something which had a platform and a handle. What has a platform and a handle but has holes in the platform? Potato masher, of course. And here we have a potato masher bought from John Lewis, but with the edges sawn off, a bit of Lego to make the hinge in there. And so this is what got us our original 300,000 then from NIHR. And so then I started going to the Royal. Now, where's Peter's here somewhere? Peter is a design engineer over at the Royal, who we'd done some work with before, and in fact the one commercial thing which we'd worked on before had been successful. So I came back to Peter and said, how can we deal with this? This is a problem, and he put his brain to it. And we had some fantastic sessions then, trying to work out, and I've just got drawings of a few, pictures of a few of them. Here's one item with a hinge in the middle. And then we realised actually we didn't necessarily need the hole in the middle, because if the platform was strong enough to press the uterus against, then actually that would be enough. After all, if you cut yourself, if you've got a piece of barbed wire by accident and cut an artery, you wouldn't start going around going, oh, now let's see what, let's get some tranexamic acid. Has anyone got any sutures? If it's spurting out, you wouldn't. You'd put your finger on it. Now, of course, we'd like to do that on a bleeding uterus, used in the technical sense. You'd like to do that with a bleeding uterus, but it's tucked too deeply inside. There is a technique you can use where you put your fist inside the vagina and press on it, but that's usually used as last line in somebody who's close to death for obvious reasons, because it's highly invasive. Yeah, I guess it's my problem, but actually pushing like that and holding it like that is really, your arms start to ache quite rapidly. And so not only is the woman and her partner watching you put your fist inside her vagina and pressing on her abdomen, you go, oh, I'm tired, can somebody else take over? And somebody else comes in and does exactly the same thing. Now, it's life-saving, that's fair enough, but actually, if you can compress the uterus, it stops the bleeding very rapidly. So, you could have potential holes in the top here, and as soon as you contracted the uterus, so long as the bleeding stopped, then that would be enough of a diagnosis. So here's quite a late model, and you can see how it's now a tipping mechanism, because we couldn't get a strong enough hinge, with these two pulleys down the side. It's still got the pressure gauge to see whether it's pressing, the pressure is well enough. And then this is March 2014. And I took a picture of this because this was the aha moment, and Peter will remember this, that we suddenly said, hang on, you don't need that central support. You can have the two support struts only, but actually they can't be that wide, so somehow you've got to put them in a triangular shape. And you can see us working out the triangles. This was just us playing with ideas on the board, and actually if you get the angles right, then you can fold that in there, and then suddenly you'll get something which looks like that, and that you can insert. And so here, a week later, then we're getting into more and more designs, and then this go back to the shed, and this is some of the models that I made. I guess nowadays you'd do them in all by computer imaging, but I guess maybe Peter and I are both a bit old school, actually having something tangible that you can hold and handle and feel, even if they look completely bizarre like this. Actually, that gives you the idea. And so, as a result of that grant, we were able to make the final butterfly design, which then is an injection moulded device, which you can fold exactly like this to insert into the vagina. You can then bring the handles together, and it's got these holes in the handle. Remember, there was a flange on that early one, so it's a safety device, so you couldn't over-insert and cause damage. This has still got it, but it's actually become the handle now. You'll see that there's a bit of a base here. We extended that so it could push into the bed, and then suddenly, actually this is the final device here, this extension here means that it can push into the mattress, and suddenly you're not doing, you could hold it like that, but equally most people in use, when we used it clinically, hold it like that, push it into the bed, and then you can just lean on it. And it's very interesting when we were doing qualitative work with women. They were saying, actually, it didn't feel imposing at all. Whereas actually when you're doing bimanual compression, one of the strange things is that you are extremely close then to the woman's face. It's quite a domineering position. It's quite an intimidating position for a woman to be in a time of great stress. And so one of the things which I didn't expect this, but when we did the qualitative work, they said actually those who had bimanual compression then also had this. Actually, the fact that the person was standing away a bit and there was somehow a little bit of a separation helped quite a lot. And so we got some clever people to make a 3D video of how it might work. And here you can see how it's inserted in the folded position. The two handles are brought together and off you go, and you can compress the uterus. And if the bleeding stops, you know that it's atonic, and if the bleeding doesn't stop, you know it's vaginal because it's trickling down the side. So you've got an early diagnosis, early way of diagnosing it just like that. And so we've gone on to clinical trials. We then put all this evidence then to NIHR, and they funded us for a clinical trial then, and we used it in 57 women who were actively bleeding and looked at outcomes. Of course, we were using it alongside normal treatment, and normally women don't die or suffer horrible injury if they've got a postpartum hemorrhage. So the women stopped bleeding, all apart from one. And so we had, 98% success rate. That's fantastic. Well, sort of, but yeah, it was being used alongside normal treatments. And pretty much every PPH study you see, it says, oh, we've got 90% success rate, this was fantastic. But actually when you submit them to randomized trials, you find that actually they're not quite as successful as you thought they were, because you were just using it in a controlled setting. So that's the story of the PPH butterfly. Where do we go next? Well, we're in the process of working with a commercial company to commercialize it and to get CE marking for it. We're, as we talked about earlier, setting up a randomized trial because we need to be very cautious, I think, of success in cohort studies. What we were really looking for, first of all, was to make sure that there wasn't any safety issues and that it was acceptable to both users and to women. But it's interesting, these number of different things that we've got going on. We've ended up having 8 different devices in development at the Women's Hospital. And there's a way in which once you... this is quite bizarre things to do. There's a few people who have taken things through. Graham and Andy's taken a number of devices through. But we're fairly rare, and they're sort of unusual skills, and you need to build a team, as Graham was saying earlier. So increasingly we're getting a team together and people are coming to us to do devices. So, yeah. So I think the take-home message from my point of view is that the way in which these happen, sometimes there's an element of serendipity, that different things align together, but you also need to be in a department, and that was the beauty for me of being in Liverpool as an academic here, was that I was given the freedom to, well, Andrew, you always have strange ideas, but go with it. See what happens. Because you never know where one of these strange ideas will take you. So you need academic freedom, but you also need collaboration. And we wouldn't have done any of this not only without designers, but also without the clinical trialists, with the experts in all that, and of course without funding bodies who will provide that. So altogether, I think it brings out success in these things, and we shall see. I mean, I say success. We shall see, and the randomised trial will show for final whether it's actually better than our normal care at the moment. Thank you very much.
I'm sure the audience has got lots of questions, so I'm sorry, gentlemen, you are going to have to come back up here and take questions, and I'll try and facilitate that. So, ladies and gentlemen, please just put your hands up if you've got any questions. I know we've got lots of visitors who might not know the etiquette. It's very relaxed in here. No one's watching. Please ask your questions. Sorry.
I've noticed that creativity is linked with sheds. What's the size of your shed?
I'm going to leave Andrew to answer that.
There's some shed envy going on.
I have a huge shed with three-phase power and split into two halves and on two levels. I have a woodwork half and a woodwork and glass I use in one half. The other half I have a lathe, a forge.
And hidden in it is a Land Rover.
Is a Land Rover.
I went 6 months ago and I was, what's in this? Oh, there's a Land Rover. Oh, okay, well.
And no end of clobber I've collected out of skips over many years.
Yeah. No, my artistry doesn't go that far. I have a small shed and a little lean-to which I use, but a lot of mine I took the early stage cardboard. I've got none of the artistry that Graham has.
Big ideas, small shed. Small ideas, big shed.
Gentleman at the back.
You mentioned as a medical student, creativity kind of gets beaten out of you. So, as a medical student, how do you foster creativity in yourself and in your fellow students?
How did I, or how should we? Do you think?
I guess in this time thing.
Yeah. I don't know, but I'm sure we need to. The trouble is, I've been in the interviewing process for medical students, and even if you take straight A's as the cut, you're still overwhelmed with vast numbers of people. But I'm sure we're excluding lots of people that would make great doctors. So some kind of, I can only think of an analogy really. I had a patient whose husband was an airline pilot who had no A-levels. And EasyJet went through a phase where they go, there's an awful lot of people, flying a plane is more like just, being really good at gaming. So they went through a phase of just saying, we'll develop this interview process and anyone can apply irrespective of their qualifications. And it was about testing their aptitude to fly a plane and be a team worker and all the other stuff you need to be an airline pilot with a knowledge of safety. Maybe we need a second layer that actually tests the skills that we need. The other thing I think which makes it really difficult if you're a medical student or aspiring one is there are several postgraduate entry courses that are 4 years, and I was involved very much in the setting up of the Scottish one, ScotGem, and there's something lovely about lecturing a bunch of first-year medical students who've all got degrees, many of whom have got 2 degrees or a PhD, because there's an adult way of questioning. We've all had the medical student who said, why do you do that? Why do you do that? Why do you do that? And eventually you go, shut up and look it up. But there's an intelligent way of questioning, and if you talk to, that's a skill that has to be acquired. And I found certainly lecturing to the postgraduate medical entries. Has anyone else had this experience? It's a breath of fresh air. You walk in and you say, interrupt me if I say something stupid, and they go, oh, what does that mean? But in an intelligent, informed way. Does that answer your question? What do you think?
I think it kind of answers the question, but what do I think?
Yeah, what do you think? Back at you.
I guess university societies that are kind of geared towards kind of like medical, devices, technology, medical creativity. I guess that would be the way, but which doesn't really exist, I think.
Yeah, or maybe you could have a year out, instead of doing an intercalated in physiology, you could have an intercalated at the local art school, or do product design, or, I think, spread your wings.
I think in truth there's far more opportunities than there was, and that's thanks to Google and the internet. It used to be that if you went back to the 50s, my predecessors as professors here at the university, why would you go to the professor? Because you'd go to the professor because you'd thought of 13 different causes of a short femur of a fetus, and you couldn't remember the last. You go, we just don't know. Professor, will you please tell us? And invariably he would scratch his head and go, have you thought of something syndrome? And they go, thank you, Professor. Now, actually, that's all a bit useless at the moment, because you'd just Google it, wouldn't you? So I'm hugely grateful, actually, that I live in an era where that's not needed, where actually in academia you need creativity. What they're not looking for is somebody who can name 20 causes of this or that, because I'd be hopeless at that. I don't have that sort of brain at all. I look it all up. But what I do have is a creative brain, a way of seeing patterns, a way of thinking creatively about situations. And I'm very blessed that I've been born at this time when there is this. But I think we can instill that through the medical school as well. And I have medical students who go out to Uganda. I have a medical student who's part of they're supposed to be doing systematic reviews, but I persuaded the university that they should do a video with me instead. And so we did a video of the ECV clinic and how do you explain to women about ECVs and how do you explain the risks, etc. And those, I think those of us who have creativity do have some influence here. And I think things actually will change. So I'm maybe more optimistic than you are.
Good.
Professor.
So I just wanted to vouch for the brain shed. What a rubbish. Maybe I can ask the two. I know you're probably not past it just yet, but if you had to have your time again, what would you change anything in your careers?
Ooh. No, I don't think so. I think it's been great. Is great. I would have liked to have met you earlier. But there's 3 phases of being a consultant. The first 10 years, you don't think you know nothing. The next 10 years, you think you know everything. And the last 10 years, you don't care. And my last 10 years have been occupied with collaborating with Andy and his team and all that other team, giving me a new lease of life. I'm a DGH consultant, and yet we've done some good stuff, I think, Andy, haven't we? And those collaborations are fabulous. You know, that's what's kept me motivated.
You still will.
And still will, yeah. Well, I haven't given up yet. Not quite, on the shelf.
I think I largely wouldn't change anything either. I was very lucky to spend a couple of years in Uganda, which was fantastic and a fantastic way of developing thinking and seeing a very different perspective. I was very lucky also to come to Liverpool and to work in the Women's Hospital, which is has been a fantastic place where to get supportive mentorship from Jacques Alfirovich and Jim Nielsen, who were both very open to let maybe a bit of a maverick come into the department and work there. I guess the only change I would make is that I took a bit of a cul-de-sac when I was an SHO and ended up doing an MD in gynecology, in doing hysterectomies and fibroids, which was fascinating. I got really into it, but having done that, I thought, actually, I want to do maternal mortality. I want to do global health. I want to, and actually using leuprorelin in women pre-hysterectomy just isn't that area. And so I went a little bit of a cul-de-sac and had to come back. So it meant that a lot of my expertise was in gynecology, and then suddenly I ended up doing obstetrics, which I think set me a little bit behind at some, but no regrets.
I think you've caught up.
Thank you.
I'm glad I'm not answering that question. Dr. Chris Evans.
Thank you both very much indeed for stimulating care and presentation. This is mainly directed to Graham, and it is, as a Glaswegian, Dr. Ozengees, have you ever spoken at the Edinburgh Festival?
been involved in the Edinburgh Festival a few times. I've performed at the Edinburgh Festival. Yeah. And I've performed, and I've been a guest reviewer for BBC for the Edinburgh Festival for reviewing other people's performances as well. So yeah, I've been involved in the performing arts in Scotland in general and at the festival quite often. Thank you. And you're a Glaswegian? Did you say are you a Glaswegian? Or? No. Okay.
I'm Liverpool through.
Right. I was in Glasgow for my early career, and the rest of my career has been in Fife.
We have exported a few positions to the Edinburgh Festival.
Right. Oh, good. Yeah.
Kevin Jones, for example, I don't really know him. Well, we're all linked with Adam McKay, aren't we?
We are. Yes. Who I've met quite a few times. Yeah.
And I was born at the Rotten Row in Glasgow. Yeah. That was very good.
Yeah, got a cheer.
Got some Ouija's. I'm still keen to get some excellent questions. Perhaps the Glasgow contingent can proffer some questions. Thor, I should explain, is one of our excellent medical students and AV technicians. Thor, what's your question?
I have a question about this idea of creativity as well, but how it's informed, obviously, your clinical practice, but has it brought you a sense of contentment having this kind of other thing that you do, but also in combination, as for both of you, combination with what you do clinically, kind of having this both artistic, but also, has it brought you happiness?
Yeah, I mean, I can answer that very easily, and then you. I didn't realise, I left full-time work 5 years ago, and I'd been a consultant running fetal medicine services, and I became known as the dead baby guy. If a baby died in our unit, I would be called in to counsel the woman, and I dealt with endless women who had babies with abnormalities or death, and so I didn't realise until I stopped that it was burning me out gradually. And when I stopped full-time work and stopped fetal medicine regularly, I hadn't realised, well, there was a kind of weight off my shoulder. But what sustained me during those years was after a bad day. You know, I only remember crying once in the hospital when 3 women who I cared deeply for all lost their baby on the same day. And between the 3 women, they'd lost 8 babies. And those 3 women came so close to having 3 healthy babies, but actually they then had 8 babies that had died between them all on the same day. But with a day like that, you either go home and drink or some other release. But for me, my release is to go home and think about the maths of a sculpture I'm making, or a diversion that is utterly fulfilling, and you can't think of anything else while you're working on that. So for me, the 2 things trade off one each other, and complement but also support each other.
Yeah, I think obstetrics is one of those, maybe general surgery as well, but it's one of those things which actually is very intense at the time, and actually trying to release yourself from that or find peace after that before you start on the next shift can be quite a challenge. And I know that I get huge comfort either from playing sport, does it, and many of my colleagues are sort of long distance runners or such like, and find release in that. But I find it either in playing sport or in carving, listening to music, writing poetry, drawings, stuff like this. This is fun, and these were always things which I did in my spare time because I enjoyed it. And I remember one of the inventions I was looking at the other day was actually a blood pressure measurer where you didn't need a stethoscope. So it was a low-cost stethoscope. You go a low-cost BP machine. You go, a low-cost BP machine. And all you did was put a tape measure around the arm, you measured it, added 10%, and saw whether there was still a pulse. And that, in theory, would tell you, is the systolic over a certain level or not, which is probably all you need to know. And if you could calibrate it correctly. So, but I remember getting huge sort of satisfaction, but that was fun stuff I did. And I never really thought that it was of any interest to others. And I guess it was only when I came to Liverpool that the people, my bosses, said, well, take it forward, see what you can do. Go and spend time with the designers, see what space there is. And suddenly we started getting grants through, and I was thinking, oh, blimey, it didn't seem to be proper medicine. It was fun, but wasn't the proper science. And so actually I've been able then to build in that creative streak within me, and that need to keep doing things, keep going. And actually that, I think, complements work very well. And within academia, it's found the perfect, because there it's really rewarded. So yeah, academia is a very good place to be if you've got creativity there. Yeah.
I'm looking around for any more questions. Oh,
Yeah.
Dr. Ryan.
Any advice on somebody with no creativity whatsoever?
Collaborate.
Yeah.
Because as creatives, we need to collaborate with people who aren't creatives, but who know the regulation. Section 3C of the something Act, you go, somebody who loves insurance and medical device insurance, actually that's critical. I can't do that. I hate doing that. Can't do it.
Also, to keep us grounded, I have a good colleague who would go, no, Graham, you've gone too far this time. That's just bonkers, So.
It's a little bit tongue-in-cheek, but many years ago it was said that corticosteroids for preterm birth, it was 17 years from the time the concept really existed till it was effectively implemented nationally, the founding principle, one of the founding principles of the Cochrane collaboration. Where are we now, with either those type of interventions or these innovations where they're definitively capable to actually then delivering to on a population basis systematically? Is it still 17 years, or are we in a much better place now?
I don't know. You answer that.
I think it's very much better now. We've solved a whole load of those hurdles, and in fact within the research structures within NIHR, there's whole pathways which are set up specifically to deliver high impact interventions. Of course, the difficulty for me as somebody who works in global health is how difficult it is to get it into settings elsewhere around the world. And of course that's about politics. We're lucky to have the political system that we do in this country. We're lucky to have the structures, things like NIHR, like the university systems, which can, we all complain about them, but if you go to Africa and Uganda, where I work, you find a very different setting where you don't have all that. And that's the challenge for us, I think, as a country. Whether you're an internationalist or not, the developing world is on our doorstep. And why are people moving to our shores? Well, it's because their wife's got and their daughter's got a 1 in 20 chance of dying from in pregnancy if you live in South Sudan. What would I do? I'd want better for my wife and my daughter. So we're all affected, and the challenge is to get into those nooks and crannies. That's where I think we need to work.
I think my answer to that is about device regulation. Andy, we know a bit about device regulation, don't we? I mean, the Tydeman tube is CE marked and is on the market this year, and it's 12 years since we filed the patent. And we've made some mistakes along the way, but device regulation is not easy, and you've really got to be in for the long haul. And I would love to see a world where it's simplified. My question for Andrew, if I can do that, is how do you get DGH consultants and medical students and people who are not academics, many of whom have great ideas, to get them into practice? How can we foster those collaborations? Because at the moment you do your training and then you go, right, I'm an academic, which I was never. I'm a hands-on obstetrician who happens to have a shed. Or you're an academic. How do we facilitate those collaborations? Anyone in the audience will answer that? Katie, you want to answer that one?
I think it's on that, it's collaboration. We all have our unique kind of skills that our personality matches to our experiences that we've kind of got through medical school, university, our work, and work better as a team.
Yeah, so just introduce Katie, the current president of the British Maternal Fetal Medicine Society, who are meeting here the next 2 days. And yeah.
No, I think that's right. Having channels for people. You're right. There's huge amount of creativity, but often if you're a junior trainee in a district general, you have this great idea, but actually nobody really wants to see it. If you take it to to the NHS, they'll often go, "Oh, don't tell anyone about it. Don't discuss it with anyone because we've got to get the IP," and they don't even know whether it's a good idea. So somehow, and I've had a number of people who've come to me just as trusted mentors who can work them through the system without, I say, look, I've got no interest in taking this patent off you, or I've got enough on my plate already, but I can talk you through the process and I can put you in touch with the right people. Make sure you register your ideas right at the beginning and then speak to trusted people who can advise you further. We mustn't block those ideas.
Yeah, and I think there's in my ideal world, in sort of Planet Graham, there would be as much of that established for innovation and invention of things as there is what might be more titled conventional research, randomized trials of one or other intervention. The innovation of inventing stuff is a much more difficult pathway than in many situations.
Well, you say that, but
talk amongst yourselves a minute.
But bedside resuscitation started. We did the first drawings 2010. It was on the market by 2014. If you take a drug, the first idea to a drug to actually getting it on the market is huge. So devices can be much easier. Because you've got the tangible thing in front of you. You don't have to go through all the basic science and all that initial testing before you get out the far end. So we can do it, but we need those pathways.
Another question?
I think the key here is collaboration, and I think one of the things that's happened since the pandemic is the fact that we've all gone virtual, we've all gone online, so we lose that face-to-face meeting and collaboration that you get with conferences like the BMFMS, which is just about to happen, because it's over the coffee break and having a glass of wine or a beer at the bar that two people from completely different spheres and maybe even different specialties, or from district general, suddenly starts to talk to the professor who's got the ideas and maybe the wherewithal to make it happen. And I think we really should be moving forward now and coming away from this and getting more into face-to-face collaboration, because I think that's where ideas come from.
Yeah, absolutely agree.
That's a very good segue as to why joining the Liverpool Medical Institution is such an important feature.
I've actually lectured here because I'm a Liverpool graduate, so I've just seen Dr.
We have a country membership section.
Well, I've just seen Dr. Evans, who took me apart at Circus, and I was in my final year because I said something very stupid.
No, the evening is not over yet. First of all, one of the real pleasures of being president for a year is I get to choose these wonderful lecturers, but I also get to thank them. And we have a tradition where we have a medal struck for each lecturer. This evening it's going to be expensive for me because I've got to give 2 medals. And so this is the President's Medal for giving a lecture at the Liverpool Medical Institution. Thank you very much.
Thank you so much.
And we'll get a cheesy photograph afterwards. Because but in this day of Zoom, I've noticed people have started putting these medals and awards behind their shoulders on their Zoom calls, so you can sort of put it on the bookshelf in an obvious place.
Yeah.
Gentlemen, we're going to go outside shortly to unveil the blood clot.
I'm going to leave now.
So you're going to put 50p in the meter and get it going. And if you want to take a seat, just to give 2 ticks. So, ladies and gentlemen, we are a membership organisation. We are very keen to have more members. It is free for medical students, nursing students, students of any description. If you're a country member, it's I think £48, and for that you get to own a bit of the building, and we've got a car park. We've got lovely lectures. You get a glass of wine before the lectures as well. It's not a bad deal, you know. So please join up. Our next lecture, and we tend to have 2 lectures a month, and we alternate between Wednesdays and Thursdays to help with people's fixed clinical commitments. Our next lecture is Professor Lawrence Allison, who is a forensic psychologist by training, but he has got a really interesting niche. He is the chap that advises the police and the army, people that make very difficult decisions under high pressure scenarios, such as someone comes across a bomb in an underground station. Do you evacuate people? Do you send the bomb squad in? Does the person to go in to get the bomb out or get the child out? How do you make the least worst decision under pressure in a time-constrained situation? He's a fascinating chap to talk to. He's written several books on the topic. He's analysed the decision processes, for example, behind the rescue of the youth football team that was stuck in a flooding tunnel underground, and that was a very successful operation and demonstrates outstanding decisions that were made. He's also analysed some very poor decisions or lack of decisions. I think it'll be a really interesting lecture to come along to, so please make a date in your diary for that. If you finished taking your photographs, and I see 1 or 2 people are still struggling with the QR code, feel free to come up afterwards. But I'm going to ask you if you could come into the foyer, and if as many of you as possible could make your way up the stairs, just so that you get a decent view, because you're going to go up the stairs and look down the stairs towards the front door so you can see what we're up to. So thank you very much. If you could appear outside. Thank you very much.